Very good evening. Myself, Dr. Rakesh Sharma. Today we are discussing about management, clinical feature, investigation regarding splenic trauma management. Spleen is the most common solid organ which is injured during blunt trauma abdomen, whereas liver is the most common injured organ in penetrating wound of abdomen in case of penetrating injury. Because the larger size, it is point to be noted. Enlarged spleen is more prone to rupture even with minor tumor. Causes of enlargement of the spleen in our country: tropical splenomegaly, some parasitic infection like malaria, kala-azar, and schistosomiasis are the main contributing factor in our country for the enlargement of the spleen is called splenomegaly. Certain hematological disorder like hereditary spherocytosis, idiopathic thrombocytic purpura, some hematological malignancy like CML, infectious mononucleosis, lymphoma, Hodgkin's and non-Hodgkin's lymphoma, and splenomegaly also occur in case of portal hypertension. This is the consequences of liver cirrhosis. Now we are discussing about the etiology for blunt trauma. Blunt injury over left upper abdomen and left lower chest may cause splenic injury. Clinical features: first, pain and tenderness over left hypochondrium and left lower chest. Nausea and vomiting of known. Pain over left tip of the scapula if large amount of the blood present under the surface of left hemidiaphragm. It is also known as size. It is very important. If large amount of the blood or fluid accumulate in the under surface of left hemidiaphragm, pain referred to tip of left shoulder and scapula. And other vitals, tachycardia, hypotension, because the rupture of the spleen is there is profuse bleeding from the splenic hilum, difficulty in breathing, because sometimes blunt injury chest also occur along with the injury to the spleen. And left hydronemothorax, hemothorax also associated with splenic trauma. What are the investigation should be done for the splenic trauma? DPL. First is DPL. DPL also known as diagnostic peritoneal lavage. Now not in use because it is an invasive procedure. Now we have some non-invasive and more sensitive investigation in our hand. But we have to know about DPL because in certain circumstances where other facilities not available, we can do DPL for diagnosis of splenic trauma. For DPL, we have to give a midline 1 centimeter incision below umbilicus, and after dissection, we put a catheter inside the abdomen, and more than 1 liter saline should be instillated, and after aspiration, there is examination of the aspirate fluid. Positive DPL is considered if RBC more than 1 lakh per cubic millimeter, WBC number 2, WBC more than 500 per cubic millimeter, presence of bile, presence of fecal matter are considered as a or presence of purulent material is considered as a positive DPL, diagnostic peritoneal lavage. But nowadays we are not using DPL because we are having fast is the focus abdominal sonography for trauma. More than 100 ml fluid collection in very splenic space considered as positive fast. Positive fast is the not an indication for explorative laparoscopy because it cannot diagnose severity and extent of the injury. Just if patient is hemodynamically stable, we have to consider conservative management even in case of fast positive. X-ray abdomen eject. Some center where CT, USG are not available, we are having only X-ray abdomen. Then We have to do chest X-ray and X-ray abdomen erect. Fracture of the left lower ribs 9, 10, 11. We have to suspect splenic injury until proven otherwise. Left side flow effusion, either pneumothorax or hydrodemothorax. Third is obliteration of the splenic outline and elevation of the left hemidiaphragm, because normally right hemidiaphragm is elevated in comparison to left. But in case there is a collection on the surface of the left hemidiaphragm, the hemidiaphragm is elevated. So there is suspect of collection of the fluid or blood under surface of the left hemidiaphragm and distortion of the fundal gas. If there is large collection under the left hemidiaphragm, so this collection or hematoma may push stomach to the right side, and a distortion of the normal fundal gas is present. Useful ultrasonography is non-invasive procedure, easily available in many centers. What is the information we can get from ultrasound? First is presence of fluid, either blood or fluid in peridural cavity, as well as fluid in the perisplenic space. Extent and presence of subcapsular hematoma. Extent and severity of laceration of stain. CECT. It is more advanced diagnostic modality in our hand. Contrast enhanced computerized tomography is the more accurate in diagnosis for splenic injury in terms of extent and severity. Management of the splenic trauma always depend upon severity of injury, grading, and extent of the injury, grading and condition of the patient. If patient is grade 1 or grade 2, but patient is hemodynamically unstable, we have to go for diagnostic laparoscopy, because the diagnostic laparoscopy gives accurate 100% sensitive tool in our hand to diagnose the intra-abdominal injury. Management of splenic trauma either by conservative or operative treatment. Operative treatment depends upon extent and severity of the injury and the condition and hemodynamic stability of the patient. If grading is low, 1 or 2, but patient is hemodynamic unstable. Hemodynamic unstable means less than 90 millimeter mercury of the pressure, and tachycardia more than 120 per minute, and SPT gradually falling. We have to go for exploratory laparotomy urgently to save the patient. There is grading system of splenic injury. Grade 1 is considered laceration of spleen less than 1 centimeter with subcapsular hematoma less than 10% of surface area of spleen. Grade 2, laceration of spleen between 1 to 2-3 centimeter with subcapsular hematoma 10 to 30% of surface of spleen. Grade 3, laceration of spleen more than 3 centimeter and subcapsular hematoma more than 50%. Grade 4, finding of grade 3 with parenchymal hemorrhage with suspecting hilar injury. In suspecting hilar injury, there is when we are doing CCT, the contrast blast is seen. Matlab some leakage of contrast in the area of hilar region. If there is a minor injury in the marginal vase of hilar, then we have to go through angiographic thromboembolization for the control of bleeding. Grade 5, hilar vessels injured with shattered spleen, enlarged spleen, broken into multiple pieces, life-threatening emergency, causing profuse bleeding, urgent laparotomy and splenectomy needed for the saving the patient. Type of splenectomy: open splenectomy, laparoscopic splenectomy. In case of emergency, we have to go for open splenectomy because we have the less time, diagnosis is not confirmed, and there is lot of blood, so we have to go to open splenectomy. When we planning for elective splenectomy, we can go for laparoscopic splenectomy, such as in case of ITP, hereditary spherocytosis, and starting staging is a procedure for Hodgkin's lymphoma, or in case of portal hypertension, or this is the part of Whipple operation, we are doing splenectomy in case of splenectomy done as the part of stomach. Point to be remembered during splenectomy. What care should be taken by ourselves during splenectomy? Number one, first we ligate artery then vein. Why doing so? Spleen strengthen. Otherwise, if we first ligate the vein, there is congestion of the vein, congestion of the spleen, and there is enlargement of the spleen. Care should be taken to avoid injury tail of the pancreas, because very tail of the pancreas is very close to hilar vessels. To clearly dissect it out from the hilar by the blood dissection using red workpiece. During this revision of the gastrosplenic ligament is containing vasa varia or short gastric artery, care should be taken. We have to clamp the artery close to spleen, not to the stomach, because chances of gastric swallow are more when we guide the we clamp the ligament near the stomach. Vaccination. Never forget vaccination against the pneumococcal and Hib and meningococcal vaccine just after surgery, and second dose after 2 weeks. In case of elective splenectomy, when we try, when we plan surgery, we have to vaccinate patient 2 weeks before the surgery. Thank you.
Milani Garajano, sir.